Okay, can everybody see my presentation? Okay, fantastic. So thank you very much. I'm really happy to be back and speaking to people in Wellspring, Alberta. I was mentioning to Bobby that I used to actually do these presentations back in 2012 in person at the Calgary Wellspring. So Wellspring has a very special place in my heart. So happy to be back here. And still, I was talking about sleep then, and I'm still talking about sleep now. So, yeah, that's been my career. So, I think I'd like to first just sort of introduce the concept of sleep generally. And if you think about it, basically, practically every species on the planet has some form of sleep. Um, but sleep is kind of a very tricky thing because it makes species vulnerable. So, they're not able to hunt for food, they're not able to defend themselves, they're not able to procreate. So, sleep must have a very vital purpose for evolution to be able to, prioritize this very vulnerable position that animals are in for a significant portion of their day. We are still understanding all of the functions of sleep. And I'll talk to you about some of the functions of sleep as it relates to cancer recovery. We do have a definition of sleep here, and I'm going to kind of walk you through this. So, sleep is a recurring, reversible, neurobehavioral state of relative perceptual disengagement from and unresponsiveness to the environment. I'm going to break this down in a moment here. So sleep is typically accompanied in humans by postural recumbence, behavioral quiescence, and closed eyes. So if I break this down, so basically it says that sleep is something that happens more than once. It's reversible, which means, we can wake up from it. It involves both brain and behavior. And it is an activity that our senses are muted for the time that we are sleeping, but they're not completely offline. They can still be activated by strong signals from the environment. So either the external environment or the internal environment. And at least in people, we sleep in a reclined position, or we're at least, if we're not reclined, we're inactive or motionless, and typically we close our eyes. So when we think about sleep stages, we have two particular states, which is non-REM and REM sleep, and REM stands for rapid eye movement, and non-REM includes 3 stages. So what we're seeing over here on this side in this image is our brain waves when we're in these various sleep stages. So, typically when we're awake and our brain is functioning, we're doing things, our brain waves are very close together and very kind of low amplitude. As we progress into deeper stages of sleep, these brain waves spread out, and then they also get bigger. So this is when we're awake, we have a lot of alpha waves. So, right, this is very, very tight, very close together here. As we progress into stage 2 sleep or stage 1 sleep, which is our lightest stage of sleep, we see some very specific wave patterns starting to come about, and those would be the theta waves. So they're starting to spread out a little bit more. When we're in stage 1 sleep, we have a very low arousal threshold. And I put here that we often have sleep state misperception. So that means that we might think we're not sleeping, but the person sitting beside us says, "Oh yeah, you were totally sleeping." We also experience in stage 1 sleep what's called hypnic jerks. And so this means that, it might be accompanied by falling or perceiving yourself be falling, but it's basically when we're asleep and we feel like our body kind of jerking, right? That actually means that we're in stage 1 sleep. In stage 2 sleep, this gets a little bit deeper, and we have another particular type of electrical pattern in our brain, sleep spindles and K complexes. So we actually spend about 50% of our time in stage 2 sleep. It serves as the transition phase from going into lighter sleep and going into deeper sleep. We have a higher arousal threshold during this stage. And then we go into stage 3 sleep. Now, for anybody who has some experience, they used to consider us having 4 sleep stages. So sleep stages 3 and 4. They found it very hard to distinguish sometimes. Even the experts who are reading sleep studies, they found it difficult to distinguish between stages 3 and 4. So then they just combine them. So now we have 3 stages of sleep in non-REM. Now, our slow wave sleep here, this is our stage 3, we have delta waves that are starting to become apparent. And these really slow waves, as they're described, this is when our brain is the least active. So our body is doing a lot during stage 3 sleep. So this is the stage of sleep that is responsible a lot for physical restoration and repair. So kids spend a lot of time in slow wave sleep, delta sleep, or stage 3 sleep, right? So that's when growth hormone is being pumped out. This is why they can fall asleep in one stage or one size of clothes and wake up in a completely another size of clothes. So they're doing a lot of growth during this time. But it's the physical repair and restoration of the body that's sort of the principal objective of the stage 3 sleep. And then we move on to the second state, which is rapid eye movement sleep. Oopsies. There we go. So this has 2 different phases in it. So the tonic phase and the fastic phase. So what is really unique about REM sleep is during this stage of sleep, our body is paralyzed. So we're not actually able to move our major muscles during REM sleep. Now, what's thought to be the function of this is so we don't actually act out our dreams, right? So one of the functions of REM sleep is memory consolidation as well as emotional regulation. So this is why dreams can be sort of hodgepodge combinations of things that happened 20 years ago, things you're thinking about now, things that have never happened that are completely imaginary, sort of, kind of supernatural, or, anything that you can possibly come up with. So this is why people might be jumping off buildings or, running away from animals or something else like that. So if you imagine having the ability to move your major muscle groups when you're emotionally so intense, so you're experiencing these emotions because you're doing these, very amazing things during your sleep. You can imagine people would get into a lot of trouble if they were able to act out their dreams during that time. So the theory is that we have this mechanism in our brain that actually shuts off our ability to move our major muscles during REM sleep. What's very interesting is there is a particular sleep disorder called REM behavior disorder. And this is when the neurons in that particular part of the brain that controls this function, they start to die off. And so people's ability to shut their major muscle groups off, they're no longer able to. And so then they actually do start acting out their dreams. So there's been some very popular media reports of this where it's usually men, that have acted out their dreams and, significantly hurt a bed partner. And they're saying, gentlest person by day, and why is this person pummeling their bed partner at night? So this REM behavior sleep disorder has been discovered to actually be a precursor to the future development of Parkinson's disease, which is a degenerative condition of these particular neurons in the brain. So very interesting things coming out of sleep science right now. REM sleep too one thing that I often get questions about is, have anybody ever heard of like the old hag? So there's, at least in Newfoundland, some folklore around this old hag. And what happens is when you are waking up from sleep, you can't actually wake up and you can't move your muscles. You can't do anything because you have this vision of this woman sitting on your chest. So the sleep paralysis is what it's called. And basically it's when your mind, when your brain kind of comes online before this function of REM sleep comes off. So you're alert and you're aware kind of what's going on, but you haven't regained the ability to move your major muscle groups yet. And often it's just for a very brief, period of time, maybe 30 seconds or so, but it's enough to have people be very scared, because sometimes they experience, hallucinations or whatnot when they're coming out of REM sleep. Again, REM sleep is really for like memory consolidation and emotional regulation. So you have those things kind of tied into this experience as well. We also have something called sleep architecture. And so we cycle through these sleep stages throughout the night. And usually each sleep phase is about 90 minutes or so. So this is hours here along the bottom, and these are sleep stages. And remember, this 3 and 4, they're combined. So this is your slow wave sleep. This is your kind of intermediary sleep. This is your light sleep. And these gray blocks here are REM sleep, and these little peaks are when you wake up. So for the typical person, they might get into bed, they might spend a little bit of time awake during the first part of the night. Maybe they're just relaxing, maybe they read the book a little bit, and then they fall asleep. They spend a little bit of time in stage 1, go down into stage 2, then they have some slow wave deep delta sleep, come back up, have a brief period of REM sleep at the beginning of the night. They bypass stage 1, go into stage 2, have some more slow wave sleep, come back up, have some REM sleep, wake up probably about 3 o'clock in the morning. That seems to be the most popular time for people to wake up at night. And then they go back down, have stage 1, 2, come back up, REM, 1, 2, have another awakening, maybe check the clock, see what time it is, go back down, 1, 2, REM, 2, awake. So if I were to put this line down the middle of the screen here, you can see a pretty big difference between the first half of the night and the second half of the night here. So in the first half of the night, our brain is really prioritizing that deep delta sleep, right? We're getting way more of that in the first half of the night. And that makes a lot of sense, because that deep delta sleep is responsible for the physical repair and restoration. So if for some reason you can't get a full night's allotment of sleep, at least for that first little bit, you're getting the physical repair and restoration that the body would need. Right? Now, the REM sleep is concentrated more towards the end of the night, and the REM sleep is responsible for more of the memory consolidation, emotional regulation, as I mentioned. But the brain waves, if I go back here for a second, so the REM sleep down here, our brain waves are very similar, very tight and very low amplitude. They're very similar to when we're awake. So it's much easier for our brain to transition from REM sleep to being awake, which is why you'll often find in the morning times, you might remember your dreams, or you're sort of kind of going in and out. Maybe you're kind of dreaming a little bit, you're kind of awake, that kind of thing. So it's easier for your brain to go in and out from lighter sleep to REM sleep to awake, because it's not a big adjustment. If your brain tries to go from slow wave sleep to being awake, that's when you get really confused, really groggy, almost like, your mind is slugging through this big, deep bog or something like that. Like it really just isn't functioning quickly. The pistons aren't firing like they need to. It's going to take a little while for your brain to come on board again. This is one of the main reasons why naps are recommended to be shorter than about 45 minutes. Because if you get a nap longer than 45 minutes, you're likely to get into that deeper sleep. And that deeper sleep, if you don't properly time it, you're going to wake up feeling worse from that nap than when you started. So that's why it's recommended for naps to be shorter than 45 minutes, right? So you don't get into that time when your brain waves look like this, right? So unless you're planning to have a 90-minute nap, right? 90-minute, 2-hour nap, something like that, which isn't a nap, I would argue. That's like a sleep, right? A short sleep. So, and that if you have a nap longer than 45 minutes, it's more likely to impact your night, your sleep the following night. So, yeah, having the naps less than 45 minutes is why. I often have people say, you know what, I don't want to have all these cycling, you know, I know that, you know, we need to be awake at certain times, but I just want to go into deep sleep. I just want to stay in deep sleep. But there are some really important reasons why we don't want to be in deep sleep forever. One of them is because there's different functions of the sleep stages. But we also want to have times during the night where it's easier for us to be aroused from sleep for various reasons. So if you think about this evolutionarily, right, if we're all kind of, you know, in the back of the cave, completely in deep sleep the entire time, we'd be easy pickings for whatever wants to come and prey on us, right? So we have to have times during the night where we're able to respond to those external or internal emergencies. So for us, we need to be able to respond to a baby crying, a car alarm going, you know, I often use this example too, like how quickly do we wake up when we hear like a cat, you know, trying to vomit up a hairball, or a dog trying to vomit or something like that. Like we shoot out of bed just like in an instant. It's like that sound just brings us out of sleep immediately. So we need to be able to wake up. If we were spending all of that time in deep sleep, we wouldn't be able to be awoken to attend to these. This is actually why kids will end up wetting the bed. They're spending so much time in deep sleep, they're not even able to attend to the signal that their bladder is full, right? So developmentally, they're still spending so much time in really deep sleep that they're not able to recognize that signal. So when we look across age and the time spent in various sleep stages, we've got time spent in minutes here, we've got age across, and then we've got the total time in bed, time spent awake in bed, stage 1, REM, stage 2, and 3. So what we notice probably most obviously is the decline that there is in slow wave or delta sleep as we age. So as I mentioned, slow wave sleep or delta sleep is responsible for physical repair and restoration. So if we want the, you know, answer to, you know, everlasting life, you know, anybody who can make us get more slow wave sleep, that could be, you know, the elixir to, you know, all of this more time and more function, because the decline in slow wave sleep is in part responsible for why it takes older, as we age, it takes us longer to recover from things than it does for children to recover. The amount of time we spend in stage 2 sleep, once we get to be an adult, it's basically stable. Same with REM sleep, which is why for many of us, we can retain our cognitive capabilities even as our bodies are failing us, right? So for that memory functions of REM. We do spend more time in lighter sleep. You see, as we gets older, this increases. So oftentimes we do report that our sleep is not as deep as it was before when we were younger, but we also spend way more time awake in bed than we did when we were younger. When we think about the amount of sleep that we need, that also changes as we age. So, you know, we've got from newborns to 65 plus, you know, if I focus here on the adults, right? it doesn't really change all that much, right? Once we hit even young adulthood, we pretty much flatten out around like the 7 to 9 times, right? So these in the darker blue would be the recommended amount or the averages. And then in the lighter kind of teal on either side, those are sort of the wings. So anywhere in that range would be acceptable. Anything outside those ranges are associated with physical and emotional or psychological concerns more so. So it's kind of like a bell curve, like anything kind of in that, the middle portion, and then anything on the ends have more problems associated with them. And I think sometimes there's an idea that as we age, we need less sleep. That's not always the case. And it's definitely not the case if we used to be an 8-hour sleeper and now we find we're only sleeping 5 hours. Like if we do need less sleep, it's maybe an hour less or so. And that's typically because the demands on our body are different as we age. So we're not needing to recover as much if we were, had a very physically active job and then maybe we're retired and we're not as physically active. But it's not true that our sleep need changes drastically when, as soon as we, reach age 65. There are two major mechanisms that regulate our sleep. The first one is called sleep drive. Okay, so this is sleep drive or sleep pressure. I'm going to use those two words kind of interchangeably. So our sleep drive increases throughout the day from the time we wake up, and it kind of maxes out at the time we fall asleep. This is controlled by a neuromodulator called adenosine. And this adenosine accumulates in our brain during the time that we're awake. And this is what actually brings on sleepiness. Interestingly, this is why caffeine works. So caffeine molecules bind to these adenosine neuromodulators. So we're not actually able to recognize the buildup of adenosine in our brain until the bind weakens and the caffeine molecules kind of go away. But then we have a surge usually of the adenosine, which is why sometimes after, caffeine is worn off, we have a little bit of a crash. That's what's responsible for that. And then this sleep drive decreases during the night as we're sleeping, as these adenosine stores also diminish. And then the process starts over again. Okay. So this sleep drive is homeostatic, right? It's always trying to achieve a balance that way. So, sometimes less is followed by more is followed by less. So it's always trying to balance things out. Same with hunger, right? So if you eat a really big meal, you're not going to be as hungry the next meal, right? If you eat less, you're going to be really hungry for the next one. So the way that the sleep drive works is, so if you sleep longer, your next night, you're probably going to sleep a little less. If you sleep a little less, the next night you're going to sleep a little more. So that's how it's always trying to achieve this balance. So you can use this sleep drive to your advantage. So there's a formula where if you take your typical sleep duration, not your ideal sleep duration, your typical. So if you say, all right, on average, I get about, 7 hours of sleep. And then you decide, okay, well, you know what? I want to wake up at, let's say, 7 o'clock in the morning. That's my wake up time. I like that wake up time. That's when I want to wake up. You can subtract your sleep duration from your wake up time, right? So if you go backwards, you can also say, okay, well, if I can subtract my sleep duration from 24 hours in a day. So if that means if I sleep 7 hours, there's 24 hours in a day, I'm going to need 17 hours of sleep pressure to build before I'm likely to fall asleep again. which would make my sort of target bedtime 12 a.m. If I want to wake up at 7 and my typical sleep duration is 7 hours, I can go back 7 hours, which makes it easy, right? It's just 12 o'clock or 12 a.m. But I'm going to need 17 hours of sleep pressure to build up. So people can get in trouble, especially when they are recovering. Now, for example, if somebody always got up at 6 o'clock in the morning because they had to get to work and they had a drive and a commute and they had to be there by 8:30 or something like that. And let's say that they were an 8-hour sleeper and they got up at 6, right? That would be, if we go backwards or forwards, they would need 16 hours of sleep pressure, but it would be their bedtime, probably about 10, right? And let's say for the past 30 years, they've always gone to bed with their partner at 9. They've watched the news, or they've watched Dancing with the Stars, or they watched a show together with their partner. Maybe they've read a little bit, but then they've usually fallen asleep around 10 and they've gotten up at 6. So, but then they're diagnosed with cancer and they say, who would want to get up at 6 o'clock in the morning if I don't have to go to work because I feel terrible and I'm not going to work right now? I'm focused on my recovery. So they say, I don't want to get up at 6. I'm going to sleep in. I'm going to sleep in until 8. And so they do that, but they don't realize that sleeping in until 8, they haven't just overnight become a 10-hour sleeper, but that's what it would be if they continue to go to bed at 10. But for the past 30 years, they have this system of going to bed at 9 o'clock, watching the show, reading a book, and then falling asleep. And their relationship with their partner is also tied to that schedule. So then what happens is they start to sleep in, because who wants to get up at 6 o'clock in the morning? And then they continue doing their kind of pre-bed routine with their partner. But then when their partner falls asleep at 10, they're wide awake. Why am I not able to sleep? Why is my partner over there snoring away and I just want to put a pillow over their face because I'm lying in bed awake? So this is where people can get into trouble, not understanding this concept of sleep drive or sleep pressure and how important the morning wake-up time is for determining bedtime. So if you sleep in based on sleep pressure, you're going to automatically move your bedtime later. Does anybody have any questions about this? This is really key concept to sort of like, how kind of sleep functions. So there are a number of factors or behaviors that weaken this sleep drive. So I mentioned spending excess time in bed. Excess time in bed, you may be able to fall asleep, but sometimes when you have, like, if you take a 10-hour or if you take an 8-hour sleeper and you move them to 10 hours, sometimes their sleep becomes really fragmented. You'll see periods of wakefulness kind of popping up in places. So their sleep just isn't as deep as it was. Geraldine, you have a question.
I am self-employed, so my work start time is different every day. And so I was wondering within what window is sort of like a good range of it's okay to sleep a little bit longer or get up a little bit earlier, because I've heard this before. I've struggled with sleep problems for a long time, but when you're exhausted, just to set your alarm on a day when you don't have to get up that early, it just doesn't really happen. So can we be within an hour and a half of our range, within half an hour of our range? Like, what would you recommend is sort of like a realistic number of minutes?
That's a really, really good question. You have more leeway with your bedtime than you do with your wake up time.
Okay.
So with your wake up time, you want to keep it a lot more concise. Like, so a half an hour on either way is better for your morning time. But if you find that you're super exhausted, and instead of going to bed, let's say at 11, because that might be, what's typical for you, you go to bed at 10, right? Like, because you're super exhausted. But yeah, the morning time is the one to try and keep as consistent as possible. If you think about an hour as one time zone,
Mhm.
and usually when we have it, when we cross one time zone, it takes about 1 day for our circadian rhythm and our body to adjust to that time difference. So that's where if it becomes more than one time zone per day, you're asking your body to, adjust to varying time zones. So your body almost becomes on like a perpetual jet lag, right? So it's like I'm flying to Ontario, I'm flying to BC, I'm flying to Halifax, I'm flying back to Ontario, and then I'm in Alberta, right? Like, so yeah, your body really is jumping all over the place. Um, and
So,
yeah,
I'm sorry, I didn't mean to interrupt.
no,
So if that's the case and that I need to go to bed earlier, then do you still believe in that principle is if you're in bed and you don't sleep for more than 20 minutes that you need to get up? Like
yes,
do you, so if I go to bed earlier, I just lie in bed, even if I'm tired. And so I don't ever really go to bed early because I just lie there. So is 20 minutes still your marker for like you need to quit and try again later?
it would be. And there's good reason for that. So you wouldn't want to go to bed too much earlier, right? So it really depends on your own sleep need. So if you're a 6 hour sleeper or something like that, you're wanting to kind of like consistency is what is best for our body. So you're trying to keep that consistent within reason. And especially for people who have had a cancer diagnosis, that cancer related fatigue can be really hard to distinguish from exhaustion, from sleepiness, right? So, like, sometimes you're just like, I am done. I have no more energy in me at all, but I can't sleep either, right? So that's where like trying to distinguish, okay, what does my body need right now? Does my body need rest or does it need sleep? And if it is something where you go to bed and you're not sleepy enough to sleep, then being in bed doesn't increase your likelihood of sleeping. Being in bed for longer than 20 minutes usually increases you being frustrated. It increases getting like annoyed and thinking about how terrible the next day is going to be because you're not. So that it basically just reinforces the bed as the place that you are frustrated, that you worry, you get angry, anxious, those sorts of things. So I'll go into more detail about like the whys of getting out of bed if you can't sleep. But yeah, trying to be as consistent within a certain margin would be the best.
Okay. My cancer put me into automatic menopause later in this presentation. Are you going to talk about menopause and sleep issues a little bit, or is that sort of outside of the scope?
No, no, no. So I almost have a question about menopause every time I talk about sleep. So for sure. And I can talk about it now, because I'm sure that it's an issue not just for yourself, but for other people as well. So what happens in menopause is that the thermoregulatory zone shrinks. So what that means is that you no longer need as much of a change in temperature for you to either sweat or shiver, right? So this is why you get the hot flashes and you followed by cold. The best way to handle it with sleep is either pharmacological, right? So there's a number of different medications out there that are helpful for sleep. Sometimes it means taking your medications. Usually they're like your aromatase inhibitors or something like that. If they're for that purpose, taking them in the morning. So it's almost like you shift your hot flashes to the day versus the night. So at least they're not disrupting your night's sleep, but you might have to bring a change of clothes during the day. There's also products out there that have been very helpful. So there is something called a chillo, which is just a colder pillow, right? It sort of keeps your head cold. And that can prevent or reduce the severity of hot flashes. There's considerable evidence out there that acupuncture, I actually did a trial that compared acupuncture to pharmacotherapy for hot flashes in breast cancer, women who had, with a diagnosis of breast cancer. And acupuncture was as good as pharmacotherapy for that. So acupuncture has evidence of efficacy as well. There's also evidence for a specific type of breathing technique for reducing the duration of hot flashes. So what happens with the hot flash is you also get activation, cardiovascular activation as well. So if you do deep diaphragmatic breathing at the start of a hot flash, it reduces the duration and severity of the hot flash. So a lot of times people tense up, tighten up when they experience a hot flash. So trying to breathe through the hot flashes can also be helpful.
Okay. I'm doing a lot of those things, so thank you very much.
Yeah, you're getting good advice somewhere.
Sheila, there's a few questions in the chat.
Sure.
One goes back to what you were talking about, I think, with the first question there. It says, does it also affect if you take a nap?
Yes. So, so that's where I'm getting to here in terms of napping. So if the nap is too long or if it's too close to the bedtime, basically it's like, you know, having a energy bar before a meal, right? It's going to take off some of that homeostatic drive for sleep. So this is the reason too why the recommendation is, if you're going to have a nap, make it kind of like either late morning or really early afternoon. So like before 3 p.m. And that's usually for people who follow a typical maybe like 11 to 7 sort of sleep phase in that way. If you're like a shift worker, or if you're more of a night owl or something like that, if your circadian rhythm is shifted, then you know how late you can get away with napping is also shifted. But if you're napping, you know, after dinner time, that's pretty much a guarantee that you're going to have an impact on your sleep that night. I also distinguish between dozing and napping. Usually when I ask people, do you nap? They might say, oh, no, I don't nap. And then I say, well, do you doze? And then almost like bashfully, it would be like, oh, okay, well, yeah, you know, maybe in the evening while I'm watching TV or something like that. And that is like where you kind of like the head bobbing, I'm kind of like dozing. Those little micro sleeps can be very powerful and can also reduce the sleep pressure enough so you have difficulty falling asleep that night.
Thank you. The next question is, what about when there are medications you need to take that interfere with sleep?
Yeah, so one of the most common ones is the corticosteroids. Right? So like that is like if people are going into chemotherapy cycles or something like that, and they're being dosed with prednisone or dexamethasone right before, those certainly are huge insomnia culprits. You know, for medications like that, which, you know, insomnia is definitely a side effect. A lot of the problem is that people aren't aware that this is a side effect. So they go into it and then they're completely caught off guard. Like, why can't I sleep? Why am I not sleeping? For these periods where they're short term and they're definitely medication induced, sometimes sleeping medications are really indicated for these sort of short term times when the medication will be used. If it's another medication that you have to take on a regular basis, which insomnia is a known side effect, that's trickier because, you know, depending if there's no other option available that doesn't have insomnia as a side effect, Sometimes pharmacotherapy can be helpful, but you also, there's some medications now that are designed to be used more long-term. They don't have the same sort of dependence profile that other medications did, but most people don't want to take another medication long-term.
Thank you. One last question. Where and how does pain fit into this?
So pain and sleep have like this vicious cycle, right? So they worsen each other. So pain can make it hard for you to sleep, right? Hard for you to get comfortable. But then if you're not meeting your sleep need, insufficient sleep can worsen your pain threshold. So it's going to take you less pain to feel the pain, right? So a full night's sleep, you'll be able to tolerate a higher degree of pain than if you don't get sufficient sleep. So pain management is really, really crucial for getting sufficient sleep in order for you to be able to function with pain during the day. So again, this is where, having adequate pain management usually starts during the hospital, but also, home too. So I'm a big proponent of making sure, you're on talking with your physician, talking with your pharmacist, whether there's creams, whether there's natural substances. Again, acupuncture, I've done a lot of work comparing acupuncture to both medications as well as cognitive behavior therapy for insomnia. And I'm not actually, I'm not an actual acupuncture proponent. So I came in with as much skepticism as everything else, being like, I don't know, I don't think this. So I was really surprised at the level of effectiveness that it did have, particularly for people with pain.
Thank you. That's it for now.
All right. Okay. And as I mentioned, about sleeping in or varying your sleep times, comparing that to time change. So we get this, a lot of the times, I'm sure everybody's experienced it, where, on Friday night, we might go to bed a little bit later, and then Saturday we'll sleep in. Saturday night we'll probably go to sleep, a little later anyways, because we slept in later. And then Sunday we'll probably sleep in, but then Sunday night we kind of want to get back on a regular schedule. And so depending on how long you've slept in, that could be, 3 or more hours. Sleeping in on weekends is basically like, flying 3 time zones, 3 or 4 time zones, and then coming back. So trying to, get that social jet lag is what it's called. Get that out of your system. It can make Monday really, really tricky. So sleeping in on weekends, oftentimes people think I'm going to catch up on sleep. And unfortunately, what it usually does is it just makes it worse. So this sort of, the way that our body works, it sort of punishes us for making, for trying to catch up on sleep. I use the analogy like, we have this sleep debt account. And how banks, they can punish you, charge you, fees or something for like making too big of a payment, right? So with our sleep debt account, we can only make small payments over a long period of time if we want to pay back this sleep debt. Because if we sleep in trying to put a large payment into our sleep debt account, we end up not being able to sleep the following night, which is where that homeostatic mechanism, so less is followed by more and more. We have to make sure that the balance is more like this and not big changes like this. So the other factor that controls our sleep is our circadian rhythm. So this is our body's built-in clock, and it is centered in the brain and the hypothalamus. And so it controls the timing of our sleep independent of how much sleep we got or the amount of wakefulness that we have. And it usually coordinates with the daylight cycle over a 24-hour period. Not only does it regulate our sleep, it also regulates our eating, our core body temperature, the regeneration of our cells, hormone production, everything else like this. So this circadian rhythm is quite vital. The circadian clock needs to be strengthened by getting up and getting out of bed at a regular time. I'm sure people know someone that doesn't need an alarm clock, right? They just wake up at the same time every day, regardless of how much they slept or what's going on. They have a very well entrained circadian rhythm. It just wakes them up at that time. It is also strengthened by the timing and amount of light exposure. So we have special cells in our eyes called melanopsin receptors. And those melanopsin receptors are only sensitive to a specific wavelength of the bright blue-white light spectrum. And this is what controls the production of melatonin. So melatonin is only produced in the absence of this exposure to light. So when we want to get up and we want to feel alert in the morning, getting light exposure first thing in the morning can make us feel more energized, can reduce fatigue, can sort of turn on our brain. So that's functioning as well. Then we want to have the opposite prior to bed. We want to make sure we're not getting exposure to that bright blue light, so we can have our melatonin cycling as it should. The circadian clock is also strengthened by other behaviors such as physical activity, exercising, food. So we get into sort of routines in our body, and that's controlled by the circadian clock.
Could you just repeat that about the melatonin?
Yeah, absolutely. So melatonin is only produced in the absence of light. And do you want, which part did you want me to repeat about the melatonin?
Well, I guess I've never understood about, like I know it's somehow produced in your body, but then what about the melatonin that people take to sleep? How does that affect?
Right. Yeah. So the pineal gland in our brain produces melatonin, and it only produces melatonin in the absence of light, right? So that's where these receptors in our eyes are super sensitive to it. So any sort of activation of that by light, whether it be from sunlight, whether people have full spectrum lights in the houses, if they're on devices that give off powerful enough light, that's all powerful enough to suppress the production of melatonin. When people are taking over-the-counter melatonin, first of all, over-the-counter melatonin has no evidence of efficacy better than placebo for the treatment of insomnia. So I know it's prescribed or it's recommended a lot. I think that a lot of the time it's recommended because people think it's relatively benign. That, okay, well, you know what, it doesn't hurt them to try it because there's no massive side effects that people know about. But in terms of efficacy, when they compare it to placebo, it's not much better than placebo. Does that help with the question of melatonin?
Well, I'm still struggling to understand. So in order to sleep, you don't want to have melatonin? Is that what you're saying?
No, you do.
You do.
Yeah, so you want absence of light prior to bedtime, so your body will produce its own melatonin.
Okay. I think I get it.
Yeah, so you want melatonin at night. You don't want melatonin during the day. So, but you want your body to function how it should. So during the day, in order to be alert and function, you want to expose yourself to bright light in the morning. So that's going to energize you, and it's going to cut off any production of melatonin that you may have lingering. But at night, when you want melatonin, then you want to make sure you're not giving your body any signals that it should not be producing melatonin at that time. So, making sure that you're not exposing yourself to bright light. Even things like physical activity can can impact melatonin production. Backlit devices are known to have an impact on melatonin production. So those sorts of things. So yes, melatonin at night, no melatonin during the day.
So is there a difference then between reading a book with a nightlight and reading a book on your iPad?
Yeah, so normally the nightlight is behind you, and so it's focused on the book. Whereas iPad, it's usually in front of you, focused right in your eyes. Now, the device manufacturers, they, of course, want you to be on devices all the time. So they have developed the night mode where you can change the type of light that's being emitted from the screen. And that's definitely helpful for not impacting your own endogenous melatonin production.
I find the issue of light and dark very interesting. Both my wife and I have been fortunate as we regard it, to live in places where we've never had to close the curtains at night. And in my wife's case, she was born and brought up in the Northwest Territories, where they have, of course, 24-hour daylight. But regardless of that, we have a consistent sleep pattern winter and summer, even though in summer we have, here in Edmonton, light until 11 o'clock at night. And when my wife was growing up in Yellowknife, it never went dark. So this it runs counter to the fact that we need darkness to produce the melatonin.
Yeah, so that's very interesting. So in places where there is 24-hour light, they have some very particular syndromes there. So sometimes when people don't have darkness, there's people who will develop psychosis-like symptoms from lack of sleep. Right. And we do know that in places where there are like 24-hour light periods, you will have people get very agitated from lack of sleep, and their sleep phase will sort of change. They'll have less nighttime sleep and more daytime activity. So we do the same, just to a lesser degree with the time change. Sometimes we notice that we sleep a little bit more when it's winter out than the summertime. So yeah, there are some interesting things with the really northern climates where there's 24-hour dark and 24-hour light.
Sheila, there's one more question in the chat box.
Sure.
How many hours before sleeping should we avoid using phones and other devices?
About an hour and a half.
Does that include TVs? Just out of curiosity, that's my question.
So one of the main reasons for it is to allow your brain to disengage. So devices can be very addictive, right? Because it's like, if you're scrolling or you're clicking on the next thing and you're clicking, they can be very hard to disengage from. So giving your body just time to disengage from that, and even just recognize the signals that your body is giving out. The disengagement from the devices is one of the main reasons for about an hour and a half. And the other reason is, just if there is light from the devices. The TV tends not to be as bad because it's not as close to your face. So, and it also depends on what you're watching. So if you're watching things that get you activated or that you want to continue watching, so if it's a series that, then if you're binge watching, then TV is not okay to be before bed, because you'll keep being engaged with the show. But if it's something that you can easily turn off or you fall asleep, right, that's no problem.
Thank you. A couple more questions have come in.
Sure.
What about using magnesium?
Yeah, so magnesium is a natural sort of muscle relaxer. So oftentimes with magnesium, I recommend it for people who have leg cramps or restless legs or things like that, because that is where it can be helpful. If you are taking magnesium, I would recommend also taking it with calcium at the same time, because calcium helps magnesium be absorbed. So it's usually in about a 2-to-1 ratio. So 2 calcium to 1 magnesium. And yeah, as a muscle relaxer, it can be helpful. And if that's what somebody is sort of struggling with, there's some potential use for that.
Thank you. Going back to the light, what about a Kindle? Is that a good light?
Well, it depends on the type of Kindle, because there's the Kindle that has like it's basically just like reading a book, right? It's got a black with like white words. But then there's also the Kindle Fire, which is almost like any other tablet. So, if it's a Kindle that is like kind of just like reading a book, not too much of a problem. But if it's the Kindle Fire, that would be more of an issue with the light.
Thank you. One more question. Why can I wake up, read a few articles on my cell phone, and then get sleepy?
Yeah, so everybody has different sleep cues, and what would work for one person might not work for another person. So what I suggest might be happening for that person is it prevents you from getting your mind on another topic, right? So it's kind of like distracting you. And then if you're distracted, you realize, okay, I am tired and I can fall back asleep. So the light might not be powerful enough in the middle of the night to completely make you alert, especially if it's just from a device, because the light that's emitted from a device is definitely not as powerful as, morning sunlight. So your sleep drive at that point is stronger than any light that's being emitted from the device.
Thank you. One more question. For a few days after treatment, I'm really tired and I want to sleep. I can see why giving in is causing me issues. What things can people do during the day, keeping in mind the fatigue? Get discouraged with sitting around. I feel I should be doing something. What activities for the cancer fatigue time do you suggest?
Yes, that's really, really tricky, especially when your mind is saying, I want to be doing other things, but your body is really not cooperating with it as well. If there are gentle activities that you can do for your body, whether that even just be swimming or yoga or walking, right? Those can be helpful. We do know that there is just a preponderance of evidence for the benefits of physical activity even during chemotherapy. So, doing something is better than doing nothing. And if there is the I should be doing something, even if I'm, kind of sitting down, trying to engage in hobbies that maybe, you didn't have before, you want to take up new ones. It could be needlework or crochet or organizing files on your computer, or maybe some of those tasks that you never got to. It could be self-care activities like I'm going to give myself a pedicure or a manicure, or I'm just going to make sure I really take care of my skin during this time. So a balance of really gentle activities for yourself, as well as things that give you joy and pleasure, and things that make you feel good.
Thank you. Some more questions have come in. How long before sleep do you take the calcium magnesium supplement?
Yeah, well, normally, if you are going to wind down, so if you're giving yourself about like a 90 minute to an hour wind down period, sometime during that period, enough for it to be able to kind of get into your bloodstream before you fall asleep.
Thanks, Sheila. Another question here. I wake up at 3 a.m. and find it hard to go back to sleep. And also I am unable to nap late afternoon. What would you recommend?
Yeah, so 3 o'clock is a very popular time during the middle of the night to wake up and not be able to fall back asleep. There could be a number of reasons for that. One of the suggestions is, so what I do with people is, depending on how they are, how long they're awake during the middle of the night. So if they're awake for an hour, I tell them to go to bed an hour later. And people usually hate that. But what that does is it really strengthens that sleep drive. And when you have a really strong sleep drive, you go into deeper sleep faster and you stay in deeper sleep longer. So you would actually sleep through that 3 a.m. normal awakening, right? So it may seem counterintuitive, or it might seem like, completely without logic to go to sleep later, the amount later that you would be awake during the middle of the night. But you really want to use that sleep drive to be very, very, very strong, to basically push you through that middle of the night awakening.
Thank you. And now just really a comment from another member. This member said, I found crafting or sketching really helped me through treatment. They have free classes at Wellspring for doing Zentangles on your own. So, we have many programs. I'd be happy to talk to you guys about that at the end. But I think that's it for now. Then you can get back to your slides, Sheila.
Okay, perfect. I've got lots. But I love all these questions. This is really great. This is basically how things work. So we've got the 24-hour period here, right? We've got 7 hours awake. And then that's 11, or we've got 7 a.m. and this is 11 p.m. So we've got a sleep period here from 11 to 7. We've got a period of being awake and another period of being asleep. So this is our circadian rhythm. Our circadian rhythm is always promoting alertness, right? So it's kind of like always pushing us up. So you can see that we're very awake, promoting alertness. And then as that is going down, we have this sleep drive. So the sleep drive is continuing to get higher and higher and higher. And when you have the biggest gap between your sleep drive and the circadian rhythm, that's when your sleep window opens. Oops, I'm sorry. There we go. Okay. So, and that sort of just like cycles. So this is how they work together, and they kind of start again the next day. But then what happens is we have this arousal system, our HPA axis, which produces all of the hormones that make us alert, usually anxious. Here's a little cartoon. Okay, let's revise some of the dumb stuff you said today. This could take a while. So this is 10:30. This is 11:17. Just quickly remember that argument from 6 months ago. And then, what now? You're going to look really tired in the morning, right? So this arousal system, this system that we have, that promotes alertness, even when we are completely exhausted. This has the function of allowing us to respond to threats in the middle of the night. So for example, even if we have fallen asleep and it's 2 a.m, but we get a call, you need to respond to this, there's an emergency or something like that. Boom, we can shoot out of bed. We're in the car, we're driving to wherever we need to go. So this arousal system has a function when it's working for us. But when it is working against us, so we're thinking about, oh, tomorrow is going to be terrible. You're going to feel miserable. You've got that thing that you have to do, and you're probably going to be terrible at it because you've just, had a horrible night's sleep, and everybody's going to know that you're, just not functioning very well. And so our mind creates these situations that get our arousal system just to the same level as if there was an actual emergency. So when this happens, we can develop a condition called insomnia. So insomnia is both just a symptom, right? A symptom that everybody has. Everybody has the occasional night of problem sleeping. But if it happens regularly, people can develop insomnia disorder. So this is a dissatisfaction with sleep quantity or quality characterized by difficulties initiating sleep, maintaining sleep, or early morning awakenings. And this is if it takes you longer than 30 minutes to fall asleep, or if you are awake in the middle of the night for longer than 30 minutes, that's sort of the cutoff. And then if this occurs for at least 3 nights per week, despite adequate opportunity for sleep, and that has been occurring for at least 3 months, that would be the diagnostic criteria for insomnia disorder. And this is typically accompanied by some sort of distress and impairments in daytime functioning. So irritability, fatigue, cognitive problems, a whole host of things. So there's the difference between the insomnia symptoms, which would be less than 3 nights per week, and maybe some less problems falling asleep, less problems staying asleep, maybe not quite at 3 months. But once it exceeds 3 nights per week and it's been going on for more than 3 months, it becomes insomnia disorder. Now, insomnia in people who have had a diagnosis of cancer is about 3 to 6 times greater than the general population. So between 30 and 50% of people who have been diagnosed with cancer report difficulties with insomnia. This does vary by cancer type, where they are in their treatment and how this is assessed. And for reference, the prevalence of insomnia in the general population is 10 to 15%. Now, there's a number of reasons why there is an increased prevalence of anxiety and depression in people who have been diagnosed with cancer for obvious reasons. We know that chemotherapy has been associated with disrupted circadian rhythms, and we know how important those are. We talked about medications, especially steroids, which are known to disrupt sleep. And we also talked about hot flashes in both men and women. But other factors also include pain, discomfort, and overall fatigue. This is one of the largest studies that actually looked across 18 months from the time of diagnosis. At diagnosis, 59% of people diagnosed with cancer had insomnia symptoms, including 28 with insomnia disorder. And when you look 18 months, these rates do decrease, but 36% of the sample still had insomnia symptoms, and 21% met the criteria for insomnia disorder. So that's a full 18 months after their cancer diagnosis. So there's some really important reasons why insomnia matters for people with cancer. So there's a bidirectional association between depression and insomnia. So the rate of depression in people with a cancer diagnosis is 3 to 5 times greater than in the general population. And we know that a diagnosis of cancer can precipitate a major depressive episode. So this study actually did a meta-analysis of a whole bunch of studies, 34 studies to be exact, and 26 out of these 34 studies had a positive relationship between insomnia and subsequent depression, which means the insomnia came first and then the depression came after. So in participants with insomnia compared to those without, those patients with insomnia were 2.2 times more likely to develop depression later on. Okay, so more than 2 times more likely to develop depression. We also have a relationship between insomnia and cancer fatigue, cancer-related fatigue. So the definition in the literature regarding cancer-related fatigue is it's a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to the recent activity and interferes with usual functioning. So this was another meta-analysis which took the data from 84 studies. Overall, the prevalence of cancer-related fatigue was 52%. So that would be 1 in every 2 people diagnosed with cancer in this research would have been diagnosed with cancer-related fatigue. And then they looked at risk factors, so things that would increase the likelihood of developing cancer-related fatigue. And so here's the number of risk factors here. But you see that the ones that people can control is depression. So the odds ratio here, this is 2.23. This is, again, people with depression were 2.23 times more likely to develop cancer-related fatigue, and people with insomnia were 2.83 times more likely to develop cancer-related fatigue. And those are the ones that we have the most control over. So the other ones were poor performance status, having received chemoradiotherapy, being female, scoring high on a measure of neuroticism, and having pain. So when we think about management, we should think about things that we can do things about. So making sure that pain is managed, making sure that depression is managed, and also insomnia. Now, this is a study regarding cognitive functioning and insomnia. So I was involved in the study. It was 1,072 women with breast cancer post-treatment. Of these women, 52% reported insomnia, and 79% were bothered by cognitive symptoms of forgetfulness, difficulty concentrating, and distractibility. So we broke the sample up by people based on their insomnia severity. So here we've got no insomnia, 20% had no insomnia, and then mild, moderate, and severe insomnia. And this is the proportion of people in those categories that had moderate or greater cognitive impairment. So you can see as the insomnia severity increases, so does the proportion of women who are reporting moderate or greater cognitive impairment. And really at the severe end, we've got 72% of women with severe insomnia reporting cognitive impairment, 60% of women with moderate, and 43% of women with mild insomnia. And then when we look at the type of cognitive problems, we've got forgetfulness, difficulty with concentration, and getting easily distracted. This is the portion with insomnia. So if they indicated yes, that they had forgetfulness, 74% also had insomnia. So you see these orange bars are the proportion that had insomnia, and those relatively, they're pretty well consistent versus the people who say no, I wasn't experiencing any of these difficult cognitive symptoms. There's some research that has looked into sleep and immunity. This was using the same data set as one of the initial studies that I talked about. It was looking at self-reported infections. So compared to good sleepers, patients with insomnia disorder were at a higher risk of an infectious episode at the subsequent assessment. So they're 1.3 times more likely to have an infectious episode if they had insomnia disorder. And patients with insomnia symptoms were at a slightly less higher risk of reporting such episodes. So 1.19 times more likely to have had an infectious episode. We looked at, in this research, insomnia, immunity, and infections, and we found that patients with insomnia disorder pre-chemo had significantly lower total white blood cells and neutrophils after chemotherapy compared to those who would be considered good sleepers. There's also some research that has looked at overall survival. So this is in 361 people with metastatic colorectal cancer prior to chemotherapy. And just a note was that sleep problems were again reported by more than half of patients at baseline. So this is overall sleep, overall survival. This is patients with sleep problems. The yellow line is no, the red line is yes. And what you see is that the people without sleep problems lived on average, I reverse that. People with sleep problems lived on average 19.1 months versus the people without sleep problems lived 21.7 months. The time to progression of their cancer was also different depending on whether or not people had sleep problems. So it was 8.3 months for the people who had sleep problems versus 10 months without sleep problems. And then their response to the chemotherapy was also different. So with people who had sleep problems, the response was 45%. versus 49% or 59% without sleep problems. So they were less likely to have a greater objective response to chemotherapy. So really what I'm trying to point out is by paying attention to sleep complaints, it has the potential to have a pretty significant improvement in overall quality of life. So there are some insomnia treatment recommendations. This guideline came out from the American College of Physicians, and it's a management. So it's basically instructing all doctors on how to manage insomnia. Their first recommendation was that all adult patients receive cognitive behavior therapy for insomnia as the initial treatment for chronic insomnia disorder. So this is pretty significant that the College of Physicians in the United States is recommending a non-pharmacological intervention for insomnia. Their second recommendation is that they use a shared decision-making approach, including a discussion of the benefits, harms, and costs of short-term use of medications to decide whether to add pharmacological therapy in adults with chronic insomnia disorder in whom cognitive behavior therapy for insomnia alone was unsuccessful. So this is basically saying that, yes, while they're recommending cognitive behavior therapy for insomnia, they recognize that it might not be available or appropriate for all individuals. So making sure to discuss options with patients. So what exactly is cognitive behavior therapy for insomnia? And as in the title, it does address behaviors and it also addresses thoughts. So this is just an example. So I spend all day hunched over a desk, railing coffee, staring at a glowing screen and reading the news. And for some reason, when the sun sets, I can't seamlessly transition into calming down enough to fall unconscious. So obviously this is not, the case for probably most of you, but it just gives you an example that we all do things that are probably not in our best interests of sleep. So working with an expert to bring all of these things in line can be very helpful. And we address thoughts. So I do a lot of thinking before I go to sleep. I play scenes in my head. I practice the things I want to say. I have endless what ifs. I make plans for the next day. I think of all the people I miss. I think of all the ones I hate. I ask myself a lot of questions. So a lot of time people with insomnia will report that, they have no problem falling asleep on the couch. But then as soon as they go to bed, they find that their mind is just active. It's racing. It's like filled with all of these thoughts. They're planning what color they're going to paint the bedroom and they're, doing all these things. So they don't actually necessarily have to be distressful thoughts. They're just a lot of mental activity in bed. So what happens is there's this, it's called a 3P model. It explains how you can have an initial trigger for insomnia, but that insomnia trigger can go away, but the insomnia persists. So here we've got time on the bottom. We've got premorbid, which means no problems. Acute, 1 to 2 weeks. Short-term, 2 weeks to 3 months, and then chronic would be more than 3 months. We have an insomnia threshold here, which means anything over this is when insomnia starts becoming a problem. So we all have predisposing factors, which makes us more likely to develop insomnia. Just by virtue of being female, we're twice as likely to develop insomnia than men. If we have sort of a more kind of stress reactive temperament, we tend to feel things maybe a little bit stronger than other people. That can make us more likely to develop insomnia. If we have medical conditions, if we have chronic pain, if we have anxiety, depression, if we have those sorts of things, if we have a family history of sleep problems, these are all things that we may not be able to do anything about, which is why it stays constant over the time. But then usually there's a precipitating event. About 3/4 of people with insomnia can reference a precipitating event. Something triggered the insomnia. And for a lot of people, it's the cancer diagnosis. So that would put them over the threshold for insomnia. But then what happens is that the impact of that precipitating event goes down with time. So you meet with your oncologist, you figure out what's the plan, you've got some support from your family, but the impact of cancer never goes away, right? And actually might make you more likely to develop insomnia in the future because you've got that, you've got less distance between yourself and the threshold. But then we start engaging in things, the perpetuating factors there, which make it more likely the insomnia is going to persist, right? We might start trying harder to sleep. We might try and go to bed earlier to give us more time to sleep. We might sleep in to try and catch up on less sleep. We might try sleeping medications. We might try a bottle of wine. We might try canceling our daytime activities because we don't feel like we're going to be able to sleep. We start worrying about the impact of poor sleep. And eventually what happens is we develop a conditioned association between being the bed and being awake, because we are repeatedly pairing the bed with being awake and being anxious or being worrying about things, ruminating about things, planning things, just a lot of mental activity. So the bed becomes the conditioned stimulus to elicit that arousal, which is why we can fall asleep usually in other places, but not in our bed. And so it's the same why we will often snack in front of the television. And even if we've had a meal, maybe 45 minutes before, we find ourselves in front of the TV thinking, okay, well, I need something to do with my hands because I'm used to snacking. Same thing can happen if we repeatedly pair the bed with sleep or with being awake. All right, I'm noticing the time here. So I'm going to actually skip a few things. All right. All right, here we go. All right, so I've mentioned some of these already. So making sure to wake up at the same time, regardless of how many hours of sleep and including on the weekends. I explained why this is. It's really because of the sleep drive or sleep pressure. And encouraging morning light exposure at least 30 minutes within 1 hour of waking. People can also use those light devices if they find it hard to get outside or if it's not sunny outside. So those light devices, and we did some research actually in Calgary here, looking at those light devices for cancer-related fatigue, and there was a significant benefit for those light devices for cancer-related fatigue as well. Designating a clear your head time. So this can be any time during the day, but most of the time kind of early evening, but devoting 30 to 45 minutes just to problem solving, planning, worrying. A lot of the time we try and push these things away, maybe things that we find a little bit more challenging to think about, but that's usually what we think about when we can't sleep at night. So do this thinking, planning earlier in the evening and remind yourself that you've already devoted that time if it reappears when you're trying to fall asleep. And this is where we were talking about before, establishing about a 90-minute buffer zone before your intended bedtime. So if your bedtime, based on that sort of calculation that I had you do, maybe it's midnight. So at about 10:30, it would be the time to wind things down, make sure that the light is dimmed, you're doing something sedentary, pleasant, and relaxing, and try and disengage from backlit devices at that time. And then do not spend time in bed trying to sleep. This is the big thing, because as soon as we try and sleep, it becomes something we need to achieve. And sleep is not something that we really have any control over. So when you're like, I'm trying to sleep, then you have a purpose. And then you usually get frustrated when it backfires. So this is where the recommendations, if you're not asleep within 30 minutes, the other person who spoke up said 20, basically, as if you're awake, and especially if you have insomnia, if you're awake in bed, there's no point in being in bed because you want the bed to be associated with sleep and not wake. So if you're awake, if you find yourself getting frustrated, getting up and going somewhere else, I suggest going back to the area you've designated as the place for your buffer zone and doing something pleasant, relaxing, enjoyable, something that is not going to create that same frustration as trying to sleep and not being successful at it. And then number 5, we can really get ourselves tied into a knot about the effects of poor sleep. This doesn't usually do us any good. It usually just creates extra anxiety, extra pressure to sleep, and both of those things reduce the likelihood we are actually going to sleep. So This is the cognitive part of the cognitive therapy. So when working with people, we actually do more to emphasize the ability to cope with the poor night. So you can kind of take a hit, take one poor night, but then as long as you don't have that additional effort and worry and anxiety, the body will course correct, right? So less is followed by more. So emphasizing the ability to cope with the effects of poor sleep. I do have some recommendations here. So both of these are really good. They're workbooks you can follow along. There are some individuals also in Calgary who are CBTI providers. If you're looking for somebody to work with, I can give some recommendations to Wellspring. But these workbooks are also really helpful. So, and that's it. I'm